I'm Janine Jagatpur. I manage the Essential Drugs Program within the National Department of Health. Okay, so we manage the selection of essential medicines as well as the rational medicine use thereof. Together with me, I have Dr. Vishen Jagatpur, who's basically going to be introducing you to the Sheila system, as well as Dr. Yassine Khan from EMG Technologies, who's basically the developer of the mobile app for this SDGs and EML. Okay, so it's important for you to remember that the master data comes from where? Okay, and as Gavin spoke about earlier today, okay, the basis of all prescribing in South Africa is in the public sector is the standard treatment guidelines and the essential medicines list. Okay, so the purpose of that is to standardize care in South Africa. Okay, if we don't standardize care, then at facility level, everybody will basically be using whatever they like. Agreed? Okay. So the SDGs and EML aims to look at the priority conditions of our country, and obviously this will then change over time and as the needs of our country changes. Okay. You also spoke about formularies. Okay. So the relationship between the EML and the formularies are such. Okay. It's actually just a subset of the standard treatment guidelines. Okay. So as Gavin said to you earlier on, we have the national SDGs and EML, which facilities and districts should be using, okay? But what's happening at ground level is not always the same, okay? And a formulary can then be adapted according to your local need, okay? So traditionally, the standard treatment guidelines have been in paper-based copy, so we really had just hard copies of the book, or PDFs which you can print out, okay? So embracing technology, we then had to leapfrog, as the minister said. Next slide. Okay, before I get to Imola, and that's where the app came into play. Okay. So Gavin briefly mentioned the system. It's called Imola, the Essential Medicines Electronic Access System. Okay. I don't have a live demonstration of the system because it's still in development. Okay. Once the SDGs and EML are developed through our process, and there's a robust process for this, okay, the master data for the regimen will be housed in this platform called EMLA. So what happens is, for example, let's just take hypertension. Okay, we decide that we're going to add perindopril to the SDGs and EML. What will happen is that regimen will be loaded into EMLA. Okay, and that's basically where the master data sits for the regimen. There will be various systems feeding off EMLA that will receive that information, including the app, which is at point of care, or Sheila, where the prescriber sits. Okay? But where you get the regimen from, it sits in EMLA. Okay? Okay. So essentially, EMLA is digitization of the SDGs and EMLs, okay? And it helps us to manage the master data. Okay? You need some control and governance in place. Next slide. Okay, so has anybody downloaded the app? Okay, besides the locals. Okay, it's quite easy. You go to your app store and you just type in EML clinical guide, and that's where the SDGs and EML can be found. Okay. Again, the rationale behind this is to improve access to these guidelines. So it's no use having these SDGs and EML that are wonderful, but nobody can access it. Agreed? Okay. So at the end of the day, we wanted to ensure that you get the guidelines. Whether you use it is another story. Okay, and that's where our colleagues will talk about the prescribing tool. Okay, I already alluded to Sheila, which Vishen will present in a few minutes. Basically, at the end of the day, the take-home message is, at the end point, we have the app, which the prescriber can use, the pharmacist or any healthcare professional. It's at the point of care. What's important that you have access to up-to-date information, okay? So as soon as we make a guideline change, like Gavin spoke about the ARV regimen, what will happen is we'll push it to the app, and there you have up-to-date information, okay? But at the end of the day, for our supply chain folks, we need to make sure that that medicine is on the shelf before we push it to the app. Agreed? So that is why we have to work together as a team to make sure that the relay race is continued, to make sure that the patient gets the medicine at the end of the day. Agreed? So now I'm going to hand over to Yassine to do a demo of the app, and thereafter, Vishen will do a demo of Sheila.
Thank you very much, Janine. My personal background is as a doctor working for and within the South African Department of Health. And about 4 years ago, I got into health technology entrepreneurship, really with the on the basis of seeing some systems inefficiencies and understanding that technology, and particularly mobile technology, is a fantastic way to address some of these challenges. And my team and I have been very grateful to have worked over quite a significant period of time, very collaboratively with Gavin, Khadija, and Janine and the team, really understanding the role of an app within a greater efficient supply chain vision, and how it really acts as a building block to what Janine alluded. Before I just jump, into the demo, the problem context, the specific problem context that the app addresses is that, very simply, for adequate and appropriate patient outcomes and health system outcomes, medical professionals need to make appropriate and compliant treatment decisions. And access to medical guidance that's locally relevant, but that's pragmatic and operational, that's up to date, and that's efficiently accessed is a key piece of health system strengthening. And mobile really plays a very critical role here, because naturally healthcare workers are dispersed, and the information coming from the Department of Health with respect to standard treatment guidelines and essential medicines is, naturally needs to be disseminated to them. So the app is very simple. It's number one, it's an app. It's a mobile app, so it's downloadable through the stores, through the Apple App Store and Google Play Store. And what it contains is sort of a package of information and tools that represent the standard treatment guidelines and essential medicines list. So the guidelines area really contains all the primary healthcare guidelines, as well as the hospital and adult level guidelines. But what we've done importantly is ensure that the content is very easily and quickly accessed. So for example, a healthcare worker wants to access treatment guidelines on tonsillitis in South Africa. So they just type in tonsillitis, and we've intuitively tagged all the guidelines with sort of common sense medical terms to ensure that access is facilitated quite quickly. But then, the medical professional gets access to the guideline, can scroll quickly down to medicine treatment, find a particular recommendation for an antibiotic. But then we go one step further from there, and what we do is we build tools that facilitate some of the complexities in sort of prescribing and decision making. So we've created a pediatric dosing tool on the basis of the standard treatment guidelines and recommendations that have come, through the expert committee behind this. A simple sort of weight band system, allowing sort of the doctor to seamlessly go from treatment pathway, find drug, get dose, and then, the sort of within the spectrum of the app when it comes to referral, I guess that was on screen, but say the doctor wanting to refer to a hospital like Red Cross Children's Hospital, merging the logistical sort of an operational content with the treatment guideline in one sort of seamless application. And there are a number of other features, making the content quite visual. So this is a particularly useful and common algorithm. So creating sort of a standardized look and feel, and making sure that one can actually zoom in on the content and so forth. And then very importantly, incorporating the understanding of evidence related to particular recommendations. So yeah, we've worked very painstakingly, Janine will tell you, with the team to incorporate for every statement mentioned, as a recommendation within the application, the specific level of evidence attached to that recommendation. There are a number of complex tools, as I've demonstrated, very similar to the pediatric dosing calculator, that seek to either facilitate complex decision making or sort of a bidirectional communication channel with the Department of Health with respect to supply chain matters. So this app can be used when practitioners on the ground want to report stockouts, and there've been a significant number of reports from various sectors coming through this portal, to things like reporting, adverse drug reactions. But some simple sort of decision-making tools that could be built. And what we did was, our team looked at complex areas of the guideline, and one particular complex area was sort of risk assessment for cardiovascular risk at a primary care level to ensure that patients are either appropriately sort of up-referred or that patients are screened appropriately for risk, and if need be, sort of early interventions and medication initiated. So, simple example, we've taken the Framingham tables for cardiovascular risk. So, a male, with a particular age group and a particular cholesterol reading, looking at his cardiovascular risk factors, gets a score that here details the risk of developing a macrovascular event like a stroke or a heart attack within 10 years. This then obviously draws the doctor back to the guidelines and saying this patient is high risk, initiate lipid therapy, but follow, other steps within the guideline and so forth. And this tool is actually quite, very, very commonly used. It just sort of empowers practitioners, primary care workers on the ground to make very quick, astute clinical decisions according to sort of local standards and compliance. And there's a lot more of this that we can do. We've obviously just sort of cherry-picked a few complex areas. And yeah, I mean, I won't sort of go into much more detail. It's basically the combination of getting the right content in the right format, making that content easily searchable, creating sort of simplicity when it comes to decision making, and ensuring that absolutely, and Janine and the team have been fantastic with this, ensuring that absolutely everybody has the app. So, promoting it at every platform, through every electronic channel that they have. And I think in one of the other sessions later, they'll cover some of the analytics and the uptake of the application and so forth. Thank you.
It's been in existence for about 20 years. And what we struggled with is that getting people to use these guidelines and buy in, okay? Because in terms of the supply chain, I mean, you can only predict to a certain amount. If everybody's going to be buying whatever they like, according to no standard, how are you ever going to predict a stock out of any medicine, right? So we need to try our best to standardize care. That we have not won that battle as yet, okay? Because through the visibility and analytics network, what we're hoping to achieve at the prescriber level is actually see what these guys are using on the ground. Okay, so we assume for hypertension, first-line therapy is hydrochlorothiazide 25 milligrams daily, but everybody else is using an ACE inhibitor, for example. That's important information because then me and my team will have to come in and then say, why are you using the incorrect medicine, and get them to use the right medicine. Okay. Otherwise, you're planning for hydrochlorothiazide, but everybody's using perindopril. And that's what's happening across the board. That's why a few months into a contract, we're out of stock, and we don't know why people are using a medicine for X, Y, or Z reason.
No, it's fine.
Okay. So with information that the data we're going to get from Sheila, at least now we'll know what's actually going into the patient's hands at the end of the day.
My name is Dishen Jagatpal. I'm the clinical M&E specialist at Health Systems Trust, and we developed the Sheila program along with the Affordable Medicines Directorate in Gavin. So basically, the reason behind the development of this is at the moment the CCMDD program is manual. That is, it's paper-based. So patients are seen at the clinic, and if they are deemed stable, they're registered on paper. The prescription is written, and somebody from the service providers either enters their details on their own system, or that registration form is scanned and sent to the service provider for action. So that process causes a lot of medication errors and a lot of script rejections for obvious reasons. So we've developed a system to automate the entire process, but it has escalated somewhat, and Gavin wants to use this as a primary prescribing system in South Africa. So this is the home page. Can you log on, please, Max? This screen just gives you a snapshot of what's going on in your facility. So all your details will be on the left, and this tells you all the defaulters who haven't picked up their medication at the pickup point. That medicine is available in real time when the pickup point notifies that that patient has not picked up the medication. If you go to manage prescriptions, can you go to new, please? The patient has to acknowledge that he wishes to receive his medication via the CCMDD program. if we just enter an ID number there, please, Max. We require some valid form of identification. The reason being, we require ID number or passport or asylum seeker number. The reason being is we don't want duplication of patients. If we don't enter that and the patient is seen multiple times at different facilities, he will receive medicines quite a few times, and we're trying to eliminate that problem because it affects supply chain management. So here you can see the patient details. The ID number was auto-populated, all of these. They can choose their pickup point using a filter system. So if they know the pickup point, they can virtually search for the pickup point here. So if you click gateway, please, and search for it, it lists all the pickup points with that name, okay, in that province. So if we want clicks gateway as an external pickup point, we select it, and that auto-populates there. If we go to the prescription tab, the date of issue is today's date. The clinic file reference number is the physical reference number of that patient's file at the facility, so we can trace the patient. You see at the bottom here, prescription is valid for 6 months. Okay, in the CCMDD, we either give 1 month or 2 month supply. At the moment, most provinces are giving 2 months. So if you choose 2 months, you see that the approximate collection dates appear. So now the patient knows upfront of when his parcels will be delivered to the pickup point, and the service provider knows which dates we told the patient to collect the medicine at the pickup points. Okay. Most primary healthcare facilities issue the first month or the first cycle at the point of care, which is the consulting room. So this is where the link happens with EMLA. Janine mentioned that all their formularies will be populated in EMLA. So somebody in a province, for example, will have an account to create a CCMDD formulary, and they will select all the medicines for that province. That list will filter into our system. So all health facilities in Gauteng will have a certain list or certain medicine formulary, and the people in Eastern Cape will have a different list dependent on what they choose. We are testing only 5 conditions for now. So if we go to HIV, all the medicines listed in the EML are here. So the first line, we're going to go to the FDC. There's only 1 dose, and we add it to the prescription form. Okay. If the patient has hypertension, can you go to indication, hypertension? There's four medicines in the primary healthcare level. So the first one is hydrochlorothiazide. There's 2 doses for hydrochlorothiazide, and we can add that to the prescription form. If the patient is also on enalapril for hypertension, we simply add it as shown. If the doctor made a mistake, he can simply remove those drugs from the prescription form. We also created protocols, which makes it a little easier for the healthcare professional. So if we click on protocol 1, it contains both hydrochlorothiazide and enalapril. So somebody in a facility or PTC will have access to create these protocols. So we're making it even easier for these guys. If we add that, you see it enters 2 line items on the prescription form. And associated with each drug is the cost, which is also managed in EMLA. So now the clinicians know exactly how much it's costing the government to prescribe the drugs they are prescribing. As long as the medicines are in the essential medicines list, it will be available here, which means that it doesn't need pre-authorizations. From the time we started this pilot in September, we have only had 2 script rejections. That's out of 1,800 patients. So that's a 0.1% script rejection. Okay. If we submit the script, it'll ask you to verify. Once you click submit, it goes in real time to the service provider for them to act on that prescription. So they package the patient's medicines, and it comes in a box or packet that you guys seen on your field trip. They will scan that barcode. Okay. sorry, let me go back one step. Here's a prescription form that's made available to them. If you go down, the signatures are on the script with all the patient details on the top of the prescription form. Once that patient medicine parcel is packaged, they scan the barcode on that package, and we are notified immediately that that parcel is ready to go to the pickup point. Can you go to the pickup point interface, please, Max? Okay, so the pickup points have their own interface. When the service provider scans that barcode, the pickup point is notified that they're expecting X amount of packages. So they can start planning for storage.
We now have a data in terms of what is being used at the patient level. So again, I stress that, you know, when we normally plan for buying the medicines, we plan really on historical use, but it's not at a patient level. So we now know what is actually being used. So that example, they're actually using, for example, hydrochlorothiazide for hypertension and not the other item, which is important, okay, in terms of predicting what to buy or planning what we should buy.
Yeah, so just to highlight that point, doctors won't be allowed to prescribe outside the guidelines. If they do prescribe outside the guidelines, they need pre-authorization on the prescription. So when they submit it here and that field is hidden for the pilot, it'll go to your PDC or some authorized district pharmacist that can authorize that prescription before it reaches the next level. So when the package is ready to be couriered to the pickup point, it appears on this column, and it gives you the expected collection date. When it arrives there, all they need to do is click here and scan with their little handheld scanner, and it'll bring it into the stock, which is the second column. When the patient arrives at the pickup point, all they need to do is scan the patient's ID. It brings up the patient's profile, and you can update the proxy details on that profile. According to the SLA in CCMDD, if the patient hasn't collected in 2 days of the collection date, the service provider needs to notify them that their parcel is still waiting for them. So it moves on to the third column where the pickup point can now notify the service provider. After 14 days, these parcels turn red, like these ones displayed here. It tells the pickup point that these parcels need to go back to the service provider. Once they scan these parcels out, it notifies the facility that those patients have now collected, and please act on and to follow up on those patients, especially for patients with who are HIV positive. Remember, they need to be 98% compliant to prevent prevent NRTI resistance. So we kind of 14 days is a bit too much, and hopefully with the system we can start changing those SLAs. So as you can see, this automated system takes all factors into account. Technically, because it's an online system, we can use it in an acute setting. So if this system is in a ward, you make that ward a demander, and your pharmacy the supplier, and you can link that with RX solutions to dispense the medications that are prescribed on the system. Okay, thank you.